and introduce myself today because I feel comfortable with that. So my name is Melissa Tibbits, and I am an associate professor and vice chair of the Health Promotion Department in the College of Public Health. And I've been at UNMC for 13 years now. Most of my research focuses on adolescent health, which is what I'm going to talk about today. And also I do a lot of work around evaluation, often of child or adolescent health focused initiatives. So that's kind of the perspective I'm coming from. And although I'm in the College of Public Health, my training is actually in human development and family studies. So I kind of bring that developmental child and adolescent development perspective to the work that I do. And so let me just share my slides here. And so today I'm talking about healthcare access and particularly what are our strengths around healthcare access for adolescents in Nebraska, and where do we need more work and to take some action ultimately as a community. And I wanted to acknowledge those who have worked with me on this project, several students and faculty from UNMC, as well as Nebraska Appleseed, who served as a community partner on this project. As I get into the presentation, you'll see that there's a lot of policy recommendations and policy knowledge that's needed to do some of this work. And Nebraska Appleseed really was able to help me and the research team understand the policy landscape in Nebraska. So before I get into this particular project around healthcare access, I wanted to really talk about how I approach work in general, whether that's research I'm conducting, a needs assessment for a community, or an evaluation of a program or policy. And I always focus on the health impact pyramid. So the health impact pyramid, which was developed by Frieden in 2015, really is saying that interventions at the bottom of the pyramid are going to have the greatest population level impact and have the lowest individual need or touch, so to speak. Whereas the interventions at the higher end of the pyramid are going to have lower population level impact, and you're going to need more individuals to be involved to deliver those interventions. So at the bottom of the pyramid are socioeconomic factors. Typically, these are things like poverty, social determinants of health, housing, things of that nature. And at the next level is changing the context to make individuals' default decisions healthy. So that would be things like messaging or strategies that don't require an individual to do anything to benefit from them. So at the most basic level, that could be things like limiting junk food in workplaces, just to give a general example. An individual doesn't have to decide not to eat junk food in the workplace if it's not there offered as an option. And I'm not endorsing that, just giving that as an example. Long-lasting protective interventions typically have a clinical component, but they're not something that the clinician needs to do repeatedly. So for example, vaccinations fall in this category. Clinical interventions are all around healthcare. I mean, I know everyone in this audience understands what would go into that. And counseling and education are more like behavioral interventions. So that those could be delivered in a clinical setting, or they could be delivered in a community setting or schools. So overall, the idea is that in a given community, we really need all of these interventions for any given topic. So they're all valuable in their own right. But if we want to have the largest population level impact, we need to focus closer to the bottom of the pyramid. And this is really mirrored kind of my evolution in terms of how I approach my own work, because my training definitely was around counseling and education. So my background is really in preventing risk behaviors among adolescents, particularly substance use disorders and risky sexual behavior. And over time, I've come to see that a lot of those behaviors or outcomes are really tied to things at the bottom of the pyramid, particularly the social determinants of health, which we talk about in public health. Things like access to high quality education, to healthcare, to safe neighborhoods, things of that nature. So I wanted to just present this so that as we go through the presentation on healthcare access, I think you'll see the need for these different levels of the pyramid and the role that socioeconomic factors and policy that can impact socioeconomic factors really comes into play. So now I'm going to jump back into the healthcare access topic for today. And stuck here. So to give some background of what this project is all about, I wanted to tell you first about this report called The Promise of Adolescence. It was released in 2019 by the National Academies of Sciences, Engineering, and Medicine. And ultimately, they convened an expert panel on adolescent health to provide an overview of different topics related to adolescent development and health, and also to give recommendations of things we could do as a society in the US to better promote adolescent health. So in this document, there are different chapters. One's focused on education, child welfare, the justice system, and the health system. So I was really interested in the health system given my focus on adolescent health. And so that's what I'm going to focus on today. So in this healthcare, health sector section of the report, there were 5 key recommendations and lots of sub-recommendations, but I'm not going to get into the weeds of that today. So for the overall 5 recommendations, the first was strengthen the financing of healthcare services to reduce the number of uninsured and underinsured adolescents. The second was to improve the training and distribution and increase the number of adolescent healthcare providers. The third was to increase access to behavioral health care for adolescents. The fourth was to improve access to coordinated, integrated, comprehensive health services for adolescents. And the fifth was to improve federal and state data collection on adolescent health and well-being. So ultimately, this report came out in 2019. There was some publicity around the report. There were a couple of journal articles summarizing some of the key ideas and recommendations of the report. There was a webinar kind of to publicize that the report was available. But really, I would say the outreach and education around the report stopped there at the national level. So you have these 5 health sector recommendations, again, lots of sub-recommendations, which I'm not going to get into today. You also have recommendations for those other sectors that I mentioned, like child welfare, et cetera. But there wasn't any follow-up, which I think often happens when we have guidelines or recommendations. We have authorities or experts telling us what would be great for us in different communities and states to do, but there isn't necessarily the training, the technical assistance, the support, or even the documentation of what is or isn't occurring around these recommendations. So that was really interesting to me. And I really agree with the recommendations in this section and others and want them to be implemented in communities, including in Nebraska. So that's really where my inquiry for this particular study started, understanding what is occurring in Nebraska around these recommendations and what else could we do. So with that in mind, with this research study, my research questions were really just that. Who are the stakeholders and advocacy groups working on these issues related to the recommendations in Nebraska in particular? To what extent are the health sector recommendations actually being implemented in Nebraska? And what additional work is needed to improve the implementation of these recommendations? So for this study, I focused on qualitative methodology. We conducted semi-structured interviews. We, as a research team and with Nebraska Appleseed, really kind of brainstormed who we knew of in Nebraska that would have knowledge of at least one of these topics, one of the recommendations. And from there, we started inviting people to participate in interviewing individuals. And as we conducted the interviews, we also got recommendations from the interviewees about additional participants. So that resulted in a total of 51 people being invited to participate and 28 actually agreeing to do so. Those who did participate represented several different sectors. Many participants came from the healthcare sector, as you can imagine. So that included healthcare advocacy, healthcare systems, and individual healthcare providers. We also had representatives from universities, from legal advocacy, from child, family, and patient advocacy groups. For example, groups that are advocating for a certain type of condition. So maybe people with autism or other characteristics, just as an example. people from public health, from state and local government, and from nonprofits. So a lot of different sectors represented here. We did interview, as I mentioned, the participants and recorded and transcribed those interviews. We developed codes that corresponded to each of the 5 recommendations, because as I mentioned, we're really trying to understand who's doing this work and what's being done and what else should be done. And then we conducted line by line coding and thematic analysis for the data analysis. So with that, I'm going to jump into the recommendations. I'm not going to talk in detail about number 2 training, because you'll see that there are pieces of training throughout the other recommendations. So I just wanted to be clear about that. But just to jump in, just as a reminder, the first recommendation was strengthen the financing of healthcare services to reduce the number of uninsured and underinsured adolescents. So for each of these, I'll give just one slide of background and then get into the results. But for the background here, in Nebraska, we know that approximately 6% of children and adolescents are uninsured. And I have children and adolescents because there isn't data available specifically about adolescents. It's always grouped with younger children. In any case, we know that we still have some children and adolescents who don't have insurance at all. For reference, in Iowa, it's about 3%. So, just something to consider. We also know that uninsured adolescents are less likely to receive the care that they need. And as a result, they're more likely to have unmet health needs. And, that in and of itself is problematic, because if people have unmet health needs, particularly in adolescence, that can affect their long-term health trajectory. So we don't want that to occur. We want adolescents and all people to get the health care that they need so that acute conditions don't become chronic conditions. So for insurance background, Medicaid provides insurance for children and adolescents with disabilities and whose family income is pretty close to the poverty level. So that already is available to adolescents. They already have this option if they have those certain characteristics. And just for additional background on Medicaid, it's a federal program, but states have a lot of flexibility in administering the program. So as I told you at the beginning, my background was in the past more on counseling and education. So this policy side has been pretty much a steep learning curve, I'll admit, because Medicaid is different in every state. It's constantly evolving. The policies are always changing, even within a state. So it's a lot for, I think, even someone who focuses on policy to keep track of at all times. And with that in mind, because there's this flexibility at the state level and how states administer Medicaid, at the adult level in particular, there's a lot of flexibility in terms of, for example, how people can become enrolled, who's eligible, things of that nature. So states have a very large say in who is covered by Medicaid ultimately. So in terms of stakeholders and advocacy around insurance, and particularly much of the conversation went toward Medicaid for kind of the reasons that I mentioned, I found that there's really extensive multi-sector Medicaid advocacy efforts in Nebraska, mostly around Medicaid expansion. So Medicaid expansion is basically making the eligibility based on income, and this is for adults. So making sure that adults who income is near the federal poverty level, it ends up being about 138% of the federal poverty level, that they automatically, if they apply, could be approved for Medicaid. That's what Medicaid expansion does. And it is focused on adults, so it's important to mention that. As I noted, adolescents who have a lower income in their family already likely would be eligible for Medicaid. So it may not come as a surprise to people that the Medicaid expansion work in Nebraska isn't really focused on adolescents, but there is a lot of research showing that if you can get eligible parents, for example, to actually enroll in Medicaid, then it opens their eyes or exposes them to the reality that their children are also eligible. And so you get more of the eligible children and adolescents enrolled. So, that's something to keep in mind. But overall, work around Medicaid in general and around Medicaid expansion in Nebraska isn't highlighting adolescents. It's not involving adolescent stakeholders, real adolescent youth workers, for example. It's not talking about how healthcare is important for adolescents. So that's something I think that's important in and of itself. There is a statewide Medicaid coalition, though, that is through Nebraska Appleseed. It brings together a lot of these stakeholders who are focused, again, on Medicaid advocacy more generally, not specific to adolescents. And, overall, I found that although there's widespread support and engagement in that Medicaid coalition, which in part is what led us to approve Medicaid expansion in Nebraska, overall, not surprisingly, because there hasn't been the focus on adolescents, because it hasn't been, I think, really explained how important Medicaid expansion is also for adolescents. Institutions and individuals that serve children, like schools, teachers, after-school programs, youth workers, they're really underrepresented in the broader Medicaid advocacy work. So that is definitely an area where there could be more outreach and inclusion of those individuals. In terms of implementation, basically, what we found from the interviews was that there were issues, several issues that were hindering the implementation of recommended Medicaid policies. So we do have Medicaid expansion in Nebraska, but there's much more that could be done to ensure that eligible people, and particularly adolescents, can actually utilize services, healthcare services. So several participants mentioned that in the state government, there is this focus on cost savings. That wouldn't surprise anybody. And, people in the room may have different feelings about that. But it does lead to specific policies that have an impact on adolescent health. So, for example, many interviewees talked about how, because the state government, who sets the Medicaid policies, who sets reimbursement rates for services provided by providers who accept Medicaid, there's really low behavioral health reimbursement rates in Nebraska. So that was, again, mentioned by several people from different sectors. Also, another thing that was mentioned was Medicaid administrative barriers. So, for example, there, as I mentioned, are things that we could do beyond Medicaid expansion. There's something called 12-month continuous eligibility, which we haven't adopted in Nebraska. That would allow a person to have to re-enroll or reprove, so to speak, that they still qualify for Medicaid on a yearly basis. Right now, we do that on a 6-month basis. And that means that if maybe families aren't as organized or don't have all the paperwork they need, or are working 2 jobs and don't have time to get to the Medicaid office, children who actually are eligible end up falling off of Medicaid. So, one of the recommendations also in the Promise of Adolescence report was to adopt this 12-month continuous eligibility. Second is express lane eligibility, which also hasn't been adopted in Nebraska. And this would basically allow people to be considered for Medicaid when they applied for other services. So things like supplemental nutrition assistance or free and reduced lunch. By applying for those other benefits, their information would also be considered for Medicaid. So again, these policies are aimed at basically making sure that people are eligible are actually getting enrolled and able to utilize the services. There also were some population-specific issues that were mentioned, such as immigrants' fear of applying for or using benefits. So there was some discussion of how immigrants felt like if they used these benefits, it would affect them in a negative way in terms of citizenship or other things. They also were, participants mentioned that immigrants can be fearful of their information being used in ways that wasn't very transparent or that they thought it would be used. So basically information being shared and what the ramifications of that would be for them. So I think the opportunities are pretty clear for this one. Definitely, as I mentioned, the behavioral health provider reimbursement rates was an issue that was discussed quite frequently. And I didn't elaborate on this, but the reason that's an issue is because when behavioral health provider reimbursement rates are low, then behavioral health providers don't take Medicaid because it doesn't cover their costs. And so that means that people who actually have Medicaid and have enrolled and could utilize services still have problems accessing some of the care that they need. The second is adopt 12-month continuous eligibility. I already discussed that. And adopting that express lane eligibility. And then increasing outreach and education about Medicaid benefits, especially for immigrants, but also for other families and individuals who may not know that they actually qualify for these benefits, both children and adults. So that's the high level summary for that one. I could really talk the whole hour about this one, but I'm going to move on in the interest of time. So the second recommendation was training. I'm skipping that because you'll see it in some of these other ones. But recommendation 3 was increase access to behavioral health care for adolescents. I've talked about this a little bit in the previous recommendation, but I'm going to elaborate a little bit more here. So in terms of background, we know that issues such as depression, anxiety, substance use disorders, and eating disorders often initially develop in adolescence. So this is really a critical time for behavioral health. We also know that behavioral health issues are increasing among adolescents in the US. And just as one example, persistent sadness and hopelessness has increased over time pretty substantially. And in Nebraska, we know that nearly all counties are mental health care professional shortage areas, in part because of issues like reimbursement and other issues that I'll talk about in this section. So in terms of stakeholders and advocacy, the great news for behavioral health is there is very extensive multi-sector advocacy. More and more, this is a topic that is talked about in the press, it's talked about in the academic literature, it's talked about at the government level in Nebraska specifically. So there is a lot of, I would say, enthusiasm for generally addressing behavioral health and making sure that we have the behavioral health workforce that meets the needs of people across Nebraska. I think those of us at UNMC know that Beacon, the Behavioral Health Education Center of Nebraska, and MMI, the Monroe Meyer Institute, are really key stakeholders in particularly building the workforce for behavioral health and making sure that also adolescents' behavioral health care needs are met. And, you know, I kind of already mentioned this, but I think what differentiates this recommendation in Nebraska from the others is that there is really extensive state and local government support. So there's, again, just a lot of momentum around addressing behavioral health in Nebraska. I will say most of the advocacy for behavioral health isn't age specific, but some of the initiatives are focused on adolescent health. So, you know, that's promising in terms of implementing these recommendations. So in terms of the implementation themes for this one, there's a lot going on. Again, as I mentioned, there's the most interventions, so to speak, for this particular recommendation. So I already mentioned workforce initiatives that Beacon and MMI have several different initiatives to increase and strengthen the workforce. There also are quite a few school-based initiatives. Federally qualified health centers have school-based health centers, which provide behavioral health care. Project Harmony has the Connections program, which links schools with behavioral health providers. MMI and the Nebraska Department of Education have some school and behavioral health integration projects. So I wouldn't say every community in Nebraska has all of these things, but there's a lot of work toward addressing behavioral health in schools. In terms of clinic-based initiatives, there was a lot of discussion from the participants of behavioral health screening in primary care, integrated primary and behavioral health care, adolescent-focused clinics, particularly in the federally qualified health centers, and telehealth initiatives aimed at increasing adolescents' access to health care. In terms of opportunities, there were still a lot of opportunities that were talked about by the participants. So training was mentioned a lot. And again, that's why I'm not focusing on it as a separate recommendation. But basically, there was the idea that we really need to train and retain rural providers as a key priority because the shortages of providers are even greater in rural areas. We need to train racially, ethnically, and culturally diverse providers to meet the needs of people across Nebraska, and really add adolescent-specific trainings, for example, around adolescent health and development, substance use, telehealth, and trauma-informed care. So as much as going on, there's still was perceived to be a need for even more training. With that in mind, people also often mention the need for financial incentives. So we already talked about Medicaid reimbursement rates. I'm not going to go into that here. But I will elaborate a little bit more on incentivizing working in rural and underserved areas. So again, people mentioned there's a shortage of providers. We want people to actually be trained in the areas that they would serve in. So we need the very limited number of providers to also train people. We need people to stay in rural areas after they're trained in rural areas. So, a lot of the recommendations around this from the participants were that we need really salary increases and bonuses, and we need to provide stipends for trainers and trainees to encourage this type of workforce development. Other opportunities were really increasing the focus on adolescents. Again, there are at least some adolescent-focused behavioral health initiatives, so that's promising. But, there is more that could be done to focus on even education and outreach around why adolescence is a critical period for behavioral health. We need to continue to build on the momentum that is in schools by developing and implementing school-based interventions. What I saw most of discussed by participants, and from just, doing a document review to see if there was anything I was missing in Nebraska, is that most of the school-based interventions focus on screening and treatment. There really isn't as much around prevention. And even in the realm of screening and treatment, it wouldn't be fair to say that those types of initiatives are widespread across Nebraska. So they are occurring, but not necessarily in a widespread way. In terms of expanding clinic-based screening and treatment, again, this is already occurring in Nebraska. When you go into primary care, for example, you may be asked about your anxiety or depression symptoms as an adolescent. But again, there's a need to expand that across Nebraska, not just in kind of isolated health systems. And I think the big thing is evaluating and showing the impact of workforce initiatives. So there's so much going on around workforce initiatives. So making sure that we know how those are working and what's going well, and are we getting greater numbers of people? Are they staying in rural areas? Are we getting the demographic diversity that we need? And are we having that geographic diversity? So there's a lot that's, I think, still could be done in that realm. So that really wraps up recommendation 3. I'm going to move on to recommendation 4, which is a more complex one because it's really 3 recommendations in one. It's to improve access to coordinated, integrated, comprehensive health services for adolescents. And I just have some definitions here for the background. According to the Promise of Adolescence report, coordinated healthcare breaks down silos between different types of health providers and specialists. So I think the idea of a medical home falls in this area. You have your primary care provider, and they help you kind of connect with other providers as you have needs that can't be met in the primary care clinic. Integrated services really are focused on more coordination, I would say, although that's the word before, but coordination between physical and behavioral health. So I'd use a quote here because I think it illustrates it well. An integrated system aims to promote communication, collaboration, and coordination between physical health and mental health care providers, youth, and their families. So typically, when people are talking about integrated services, it's a little more intense collaboration is the way I would describe it. And I'll talk a little bit more about that on the next slide. Comprehensive health services, which is really what got me interested in some of these recommendations to begin with, are when healthcare considers the holistic needs of a person, from their medical needs to their social needs. So this is linking healthcare with things like public health, with social services. So that's one that I'm very much interested in as someone working in public health. So again, I'm just going to leave it at definitions for the background here. But in terms of the implementation themes, I will say I didn't ask a separate question about stakeholders and advocacy groups for this one because I knew it would cut across some of the other recommendations. So I don't have a slide for that. But in terms of the implementation themes, coordinated care came up a lot, that in many clinics, they are doing those behavioral health screenings in primary care that I mentioned for the last recommendation. And that this also can look like things like behavioral health referrals and telehealth. So when a primary care provider refers to a behavioral health provider, or when a primary care provider in a rural area uses telehealth to help a client access behavioral health care in another area. So those were really the examples that were coming up of coordinated care. And there definitely is evidence of that in Nebraska. In terms of integrated care, there are multiple levels of integration that could be utilized. One is this co-location. So that would mean having a physical and behavioral health provider in the same building, so to speak, or the same office. Next level of integration would be really, as the name implies, integrating behavioral health providers in physical health clinics. So not only are you co-located, but you're really working together a little bit more, and in some cases a lot more than in the co-location setting. You may be actually have a behavioral health provider that's on call, so to speak. So as a physical health provider, if you see a behavioral health issue, you could call that behavioral health provider into the room. That's one example of how this integration can occur. But it's really this idea that the behavioral health and physical health provider are working together in a much more collaborative, coordinated way. And there are a lot of initiatives around that, really led by MMI in particular, and also Nebraska DHHS and the Nebraska Medical Association have an initiative. And then something else that can occur but doesn't appear to be as common in Nebraska is this idea of integrating physical health providers in behavioral health clinics. So that's kind of another option out there. But there also was a lot of enthusiasm around this idea of integrated care and how do we better integrate physical and behavioral health care. The third piece, as you know, was comprehensive care. So the federally qualified health centers, including the school-based health centers, were mentioned as kind of the pinnacle of this being achieved in Nebraska. And that, for example, someone gave a scenario where the school-based health center staff would meet with the school staff, for example, and talk about the needs of particular students who obviously they signed approval for that to occur, for that record sharing to occur, but it allows the education and the physical health communities to come together to really try to best meet the needs of children. Other things that were mentioned were multi-tiered systems of support in schools, which is really led by the Nebraska Department of Education. One that is occurring, I think, more and more, but also I wouldn't say across Nebraska, is this idea of navigators or care coordinators in hospitals or clinics to really try to address those social determinants of health, to really link patients in hospitals in particular and in clinics with social services and public health services that would meet their broader needs. And then the final one is something called certified community behavioral health clinics. And we have a couple of those. They're funded right now by SAMHSA. Other options in the future would be to fund those certified community behavioral health clinics through Medicaid. But ultimately, this is kind of that model of having a behavioral health clinic that also can meet physical needs and other social needs. So I think those are the examples that were talked about the most by the participants. And so what I found with comprehensive care is there were a lot of examples, they're just not necessarily implemented in multiple settings in Nebraska. So for opportunities with this one, really there's definitely opportunity, and it should occur that healthcare and social services are able to be linked in some way. And that I think starts by assessing and addressing the social determinants of health within clinical settings and building relationships that allow for health and non-health providers to work together. So the next one is continuing to implement initiatives focused on embedding those physical and behavioral health services into schools, and I think also other adolescent serving organizations. So after school programs, for example, are another setting where these types of physical and behavioral health services could be offered. Providing Medicaid reimbursement for time spent on care coordination and integration was mentioned a lot by the participants. Just this idea that if you're doing kind of warm handoffs for even between physical and behavioral health providers, that's often uncompensated time. So, accounting for that, or if there isn't a navigator or care coordinator in an organization, the time a doctor might spend trying to locate, or the doctor's employees also might try to spend locating services, social services or public health services for a client, again, may not be compensated, but is really desperately needed work. So, that was mentioned quite a lot. And then the last one would be funding the community behavioral health clinics through the Nebraska Medicaid program. That was another recommendation. So the last one, we're nearing the end, was recommendation 5, improving federal and state data collection on adolescent health and well-being. And I'm going to keep this one really brief, but basically, for themes and opportunities in terms of implementation, what I found is that data about adolescent behavior is available. So for example, we participate in Nebraska in the Youth Risk Behavior Survey, and there's other national surveys that we participate in. So we can say, for example, how many youth used alcohol in the last period of time, let's say year, how many youth engaged in certain sexual behavior, how many youth ate their veggies and exercised the recommended amount. We can talk about that. There is data about that. But when it comes to adolescent healthcare, it's really not available. I'm not going to say it doesn't exist. I'm sure it does. But in terms of the data that is put out by organizations to talk about health status and healthcare in Nebraska, it doesn't focus on adolescents. In some cases, there are data that focus on child and adolescents in a combined way, and that is something that I'm grateful for. But really, we know that adolescence is this unique developmental stage. It's the transition between childhood and adulthood, and there are unique needs and there are unique healthcare needs. So, it's a challenge when we don't have any healthcare data about adolescence. So clearly, opportunities are to track adolescent-specific information about physical and behavioral healthcare access and healthcare needs in Nebraska, to improve collaboration between state and community organizations to facilitate adolescent health data sharing, and to really evaluate community-based health services and use the findings to improve care for adolescents. So there isn't as much of this going on as I think we would hope. So just in conclusion, I think there are a couple of overarching themes across the recommendations. The first is that adolescent healthcare really hasn't been prioritized in Nebraska. And that might seem like a bold statement, but I believe that the evidence really backs that up. We definitely have people who care about adolescent health and who are providing excellent adolescent health care. On the other hand, when it comes to statewide initiatives or even at community levels in cities, adolescent healthcare isn't being centered. It's not being discussed. It's not a focus of advocacy or policy efforts. So there really is a lot that we can do to better serve adolescents. Again, healthcare worker shortages prevent access to care. And I know that's a common theme that we discuss across UNMC, so that won't surprise anybody, but it definitely plays out in the adolescent health realm, particularly because even many healthcare providers like pediatricians or those in family medicine, they don't necessarily even get extensive training on adolescent health in some cases. So, not only do we not have enough people working in healthcare, but of those who are working in healthcare, they may not be trained to specifically care for adolescents. So again, a lot of work needed in that realm. As I mentioned, there's a lot of examples of comprehensive health services in Nebraska, but they're just not very widespread. They're pretty uncommon. So we need more of that. We need more of the linkage between healthcare, public health, and social services. And then, I think it goes without saying that Medicaid policy changes could improve access to care. And I think what all of this really amounts to is that we really need advocacy for policy change. And, from talking to the stakeholders that we interviewed and looking at the initiatives that are going on and thinking about what advocacy is occurring around Medicaid policy or other policy, it's just really clear that those who are most invested in adolescent health, including, I guess, parents would fall in that category too, but definitely those working in schools and after school programs, in some cases, physicians serving adolescents, they're not as engaged in policy change. And I think that much like we can't put out national recommendations and expect everyone to instantly be able to implement them, we also can't say, well, you're not involved in advocacy, you should be an advocate. I think there's a lot of training and education that is needed for various populations to help them understand the role of policy in adolescent health and the role they can play in advocating for better options for adolescents. So I'm going to leave it there and open it up to questions at this point. And the webinar format is new to me, so.
Great, yes, thank you so much. That was fantastic. Yeah, if you want to ask questions using the Q&A function, you can, or you can also raise your hand and we can unmute you. It does look like we have one question, which I can read. Is there room to explore surveys to parents, families, and teens and their perspective on what they see as needs or missing needs for healthcare? And then as a follow-up, is there a willingness or interest from key stakeholders, rural communities, to have care focused on adolescent health?
That's a great question. So I think that there actually is a study that was conducted through the Center for Reducing Health Disparities with Nebraska DHHS around healthcare for children and adolescents, I believe. And I can link you to that after this call. So I believe that study looked at what parents in particular were expecting for healthcare. I think it may have focused particularly on behavioral healthcare. So some of that has occurred. I think it's a challenge at the state level. It's not impossible, and it's a great idea because we do want to know what the stakeholders themselves, those who would utilize the services, actually value in healthcare. And that is really emphasized in the Promise of Adolescence report as well, that we should be getting the input of adolescents so that we're tailoring healthcare to what they actually want and need. So I think that's a great idea. It's challenging to do, I think, at the statewide level, but not impossible. And again, I do know that there was one study already in that similar vein conducted through the Center for Reducing Health Disparities at UNMC and through Nebraska DHHS. But yes, definitely always centering the actual experiences of those who are using the service is, I think, critical. And in terms of the willingness or interest from key stakeholders and in rural communities to have care focused on adolescent health, that is one I don't know the answer to. We did have stakeholders throughout Nebraska who participated in the interviews, and there was a big focus on the need for care in Nebraska. But in terms of kind of, is there community interest and political will or acknowledgement that adolescent health is something unique that should be receiving kind of special attention, so to speak, I'm not sure about that. I didn't really see evidence of that necessarily, but it is a great question and something to further explore.
Great, yes, thank you. And just as kind of a follow-up to that, did you find any discrepancies in insurance coverage or any of these service availability in rural communities that was maybe different than those faced by urban dwellers?
That's a great question. And I actually haven't seen data about that at all, especially for adolescent healthcare, because as I mentioned, if you're looking at reports of healthcare in Nebraska, it's not focusing on adolescents specifically. But that I'm going to look into that further and see if I can find information out there about that, because it's a great point. Where I heard that there were barriers to care was not so much urban and rural from the interviewees. It was more around immigration status, around just a general lack of outreach and education about the Medicaid eligibility or what services Medicaid could cover. So I heard it on a more general level, and we did ask participants for all of the questions to, in their back of their mind, keep any disparities they see between urban and rural in their mind and share that with us. And that didn't really rise to the surface. So I'm not going to say that it isn't potentially an issue. I think it could be, but it wasn't what was discussed by the interviewees necessarily. It was more a general lack of knowledge and general challenges people face trying to enroll in Medicaid in particular, or get care in rural areas.
Okay, great. Thank you. And then we did have another question. Is there much happening across the state to address more specifically the increases we've seen nationwide in adolescent internalizing concerns, things like anxiety, depression, suicide? And could that provide an opportunity to raise awareness about the need for adolescent access to behavioral and mental health care services?
Yeah, this is a tough one because there is actually so much going on to address behavioral health for adolescents. All of the school-based initiatives, much of what MMI is doing. I haven't seen it. Many of these initiatives have been occurring for years, long before we've been seeing these more recent, in some cases, seemingly COVID-related increases in behavioral health challenges. So, I wouldn't necessarily say they're in response to that, but they certainly can address that. I would say, and from what I know of what's going on in schools and different settings, and from what the interviewee said, aside from that, I know that it's not just externalizing behaviors that are getting services, if that's kind of what the question is wondering about. It's not just behavioral problems that are receiving, people with behavioral problems who are receiving this behavioral health care. I know that anxiety, depression, suicide are on the radar of the individuals working in Nebraska. And I think the question disappeared because I was too long-winded. Let me see if I can. There's a second piece to it.
Go over to the answered tab. You can see it again.
Yeah, I see it now. But yeah, is there an opportunity to raise awareness about the need for access to behavioral and mental health services? I think now is the prime time for that, because there, again, is so much momentum across the whole state, at the government level, at the school level, at the healthcare level. There's so much acknowledgement that this is an issue. This is the one area of the recommendations where I feel like we're definitely on the right track. Even though there's more to do, there always is. There is a lot of momentum for this one. So yes, I think though there's always room to raise more awareness about these issues as well.
Great, thank you. And any other questions before we wrap up? And if people want to learn more about your research or any of your findings, is there a resource they can go to?
I think the best would be just to email me. It's mtibbits, Tibbits at unmc.edu. There's a full report that we developed for this. I'd be happy to share with people if you're interested in learning more about the findings.
Okay, great.
And I think we have a raised hand from Jesse, perhaps.
Yeah, let me unmute you. Give me just a second. All right, you should be unmuted.
All right, then I had to unmute myself also. Can you hear me now?
Yes.
Yes.
Yep.
Okay.
Thanks.
Oh yeah, I just think that Melissa, thanks for glad to hear your talk here. I just want to comment. You mentioned that there's not, I can't remember exactly how you said it, not a lot of interest, or there has been a focus in Nebraska on adolescent health. And as an echo, I agree with that, just because I've been here about a year now, and I just kind of brought in here as an adolescent specialist to try to help address some of those needs, at least through children's and UMC's point of view. And I get, having come from a children's hospital, like out of Seattle Children's in Washington area and Texas, this whole part of the country doesn't have any adolescent specialists in it, or it's very rare. And so that is something I'm trying to address, but I agree that that's something that I'm trying to focus on. So I really appreciate your talk. And I think there's a lot of things there that we surely could build on. And I was always curious. I always try to work with schools or trying to get into schools. Maybe I'll talk to you later if there's any database of schools that don't currently have school-based health. Because I hear you're saying there is a lot available for that, and that's really a big initiative. And I feel like in Omaha, I know that there's a lot of that, but I don't know if there's schools further away or out west that have that or don't have that and are interested in that. I'd be curious to learn about that.
Yeah, that's a great question. I actually have to say I don't know across the whole state which communities do or don't, but I have some ideas of who might know. So we definitely should connect afterwards and try to understand that, because I think it does tie in with this idea of making sure that adolescents are served in rural areas as well. But yes, I agree that, we've talked before that there is that lack of specialists around adolescent health care. And, I think adding to that is maybe just a lack of political will to address that, or the acknowledgement that that's an important population to serve. So, I'm always looking for collaborators and people to work on these issues, and would be happy to talk about that more.
Yeah, perfect tonight. As being from a rural area myself, I feel like also with there not being the specialty in just the general Nebraska, Iowa, Dakotas, Kansas area, I don't know that there's awareness in general of that as being a specialty.
Yeah.
And I think it also trickles down to parents in rural communities are just not thinking of that as a priority. And then like the politicalness or whatever you want to call it, people may say, yes, we want to take care of teens, but then they don't want our teens to get birth control or something like that,
Yeah.
So some of those are the barriers, but anyhow, thanks for the talk and the research.
Yeah, thank you. And I think it ties in with this idea that adolescents are a problem to be solved, rather than us as a community and as a state understanding that adolescents have a lot to offer. And the first step toward them being able to reach their full potential and thrive and offer things back to the community is to have health, both physical and behavioral health. Right. So, that's a lot of the message that I try to convey, but it is a little bit of an uphill battle at times.
And that's also why I've been trying to figure out the cost problem with Medicaid to giving good reimbursement to behavioral health. Mm-hmm. I feel like that's one of those things where I know government-wise, everybody wants to save money, but I always wonder if they're saving money in the short run, but they could be saving more money in the long run if you're able to address some of those needs and reduce adult depression, substance abuse that starts when you're a teenager. So I was wondering I've always been trying to look, and I think nationwide, we're trying to look for ways to quantify that to make it look more appealing to state governments to fund behavioral health better, thinking that it might be an investment to save money later on. I don't know.
Yeah, that's a great point. And actually, when legislation is proposed, there is a branch of the government that will do that cost benefit analysis. But something that also came up in the report is that the government or state cost benefit analysis often doesn't match up with other experts in Nebraska's analysis of what the costs or benefits would be. So there can be discrepancies in those types of things. And it's really important because it does play a role in some of the decision making at the policy level, because of course, it is important to control costs. Ultimately, the state doesn't have limitless funds. So yeah, there's some really interesting issues with that as well. And I think that's a role that UNMC can play in providing more expertise around that, and that we have played as a community over time.
Thank you.
All right, great. Well, thank you, everyone. And thank you so much, Dr. Tibbits. That was fantastic.
Well, thank you. Thanks, everyone, for attending.
Thanks. Yep.